Good afternoon. This is David Henry. I'm the Communications Manager for the City of Amarillo. I want to welcome everyone to today's Zoom interview with our panel to discuss how to stay healthy and safe in the holiday season regarding respiratory illnesses in Amarillo. Let me go ahead and quickly introduce who is on our panel today. We are joined by Casey Stoughton, Director of Public Health for the City of Amarillo, Dr. Brian Weiss, Chief Medical Officer for Northwest Texas Hospital, Dr. Michael Lamentier, Chief Medical Officer for BSA, Dr. Todd Bell, Public Health Authority, and Rodney Gonzalez, Director of the Amarillo VA. We're going to open it up to our panel members to make some opening statements, and then we will take questions from our media who are in attendance via Zoom. We'll go ahead and start with Casey Stoughton. Casey, how are you today?
I'm good, Dave. Thank you. Good afternoon, Amarillo. It's been a while since we've gathered together as a group to talk about our health and our healthcare system. So we are glad to be here with you today. But each fall, we do expect to see a rise in respiratory illnesses like RSV, flu, the common cold, and now COVID. And so this fall, however, we are starting to see an early and exceedingly high number of those cases. And so we wanted to gather with you to just talk about some prevention methods and things that you can do to keep yourself safe this fall and this respiratory season. Vaccination, of course, is the number one method that you can use to stay safe. There is a vaccine against the flu virus and against the COVID virus. The best thing is that those vaccines can be administered at the same time. And so don't delay being vaccinated. You can get vaccinated today if you haven't been vaccinated. Other prevention methods include staying home if you're sick. Consider masking if you're going to go out of your house, indoor public spaces, especially those that are crowded. If you are sick, certainly stay away from others. Wash your hands frequently. If you have a cough into your elbow or into a tissue. Avoid touching your eyes, your nose, your mouth. Many of those same things that we've talked about for so very long. The same things that we've talked about that help prevent COVID will help prevent these other viral illnesses. We're going to hear from our medical providers, from our hospitals and our health authority, Dr. Bell, and they're going to give us some more tips and talk about our hospital capacity. So I'm going to turn it over to Dr. Weiss. And Dr. Weiss, thank you for joining us today.
Great. Thank you, Casey. Well, I have to say it is great to be back with my colleagues here. Unfortunately, is once again to talk about another viral threat to our community. And this time it's not just COVID. We've talked enough about COVID, but this is the tridemic everyone's talking about. So this is influenza, the respiratory syncytial virus, RSV, and then COVID all put together. And they're coming at us fast and furious. And I thought from the Northwest Texas perspective, it was important for us to talk today with the public because we've seen some rather concerning numbers coming through the hospital, particularly over the last few days. And so in particular, we have two what are called satellite emergency rooms. These are emergency rooms that are not immediately attached to the main hospital. Now, what we're seeing over the last couple of days is that these emergency rooms are seeing over 200% of the number of patients that they were originally designed to see. And that's very concerning, mostly because first, it overloads our staff there at those hospitals. But secondly, when you're hitting 2%, 100% of our capacity, you actually physically overload the building. So we're having trouble in terms of beds, even having people stay safely in the waiting room at these facilities. When you look at what's driving people to these facilities, primarily it is symptoms of these respiratory viruses. So it's the flu, it's RSV, and it's COVID. And the reason it's important is because, again, emergency rooms are for people who are sick. I mean, and have maybe even life-threatening injuries or sicknesses, and they really shouldn't be for people who are just wanting to be tested for virus or have mild to moderate symptoms. And I'll let Dr. Bell at the end talk about what are the warning signs that would have you go to the emergency room versus going to a more appropriate level of care, maybe your primary care physician, maybe an urgent care clinic, where you could get taken care of without the need to actually come to the emergency room. Now, if you look at our testing in the hospital, so if you remember, we do these respiratory panels where we use PCR to look at multiple viruses. In particular, every day we report out influenza, RSV, and COVID. And we've done typically about 200 tests a day, which is Again, about 100 more than we were doing a couple of weeks ago every day. And what we're seeing is that about 35 to 40% of those tests are coming back influenza. So we are seeing a rapid rise of the flu. And then but typically about 5 to 15% of those tests are coming back either RSV or COVID-19. And then every so often we're getting that rare individual that has 2 to 3 together. And that's a very scary proposition for those people. I know you've heard a lot about, well, what about pediatrics? We've heard this RSV and saying, upwards of 80% of pediatric beds in the country are occupied right now. We're no different. For the last 2 weeks, we've literally been on a case-by-case situation every day for our pediatric beds, because we're always bumping up against our maximum capacity for pediatric beds, both in the pediatric ICU and on the pediatric ward. So really the message today from Northwest is, boy, once again, we're seeing these viruses threatening the resources we have to provide to people. And we're asking people to please be very conscientious about what resources you're looking for if you are sick. I will now pass it on to my good friend, Dr. Lamontier from BSA.
Thanks, Brian, and good afternoon, Amarillo. Again, as Dr. Weiss stated, getting back on some of these press conference calls to communicate to all of you what's happening in the community in terms of acute health issues that are taxing our health system, what's affecting our community members in terms of illness. I think it's a good time for us to be able just to inform people and really kind of reiterate what some of the things are that we need to do to try to keep ourselves safe, keep our families safe, and understand what we should be doing when we do get acutely ill. I'll start off with just giving you some stats at BSA that I think would be helpful to understand where we are currently. We have 316 patients in the hospital this morning. That's a very high census for us. Of the 316 patients, 22 of those patients have COVID-19. And the concerning thing about that is that we were running consistently for several months now, anywhere from 5 to 10 patients, and not breaching that 10 patients total on the inpatient side for COVID, and now being up to 22 and really kind of hovering from 15 to 20 over the past, I would say, 3 to 4 weeks is a little bit of a concern this time of the year. But as Dr. Weiss mentioned, it's not just COVID. We are seeing a tremendous uptick in our flu rates as well. And also seeing RSV, that respiratory syncytial virus, which typically is a virus that affects children predominantly, but it also can infect adults. And we have some adults admitted with co-infections with both COVID-19 and flu, and some with flu and RSV. And that, again, is a potential very serious issue for patients that certainly have comorbidities, for patients that are more elderly or they're very young, or patients that sometimes have normal immune systems and unfortunately get infected and are having a more severe course. I think if you were to ask me kind of what the theme is with COVID now, I would tell you that although we're seeing an uptick in COVID admissions, we're not seeing the same severity that we saw in the past in terms of patients requiring mechanical ventilation. So for instance, of the 22 patients we have with COVID in the house right now, only 4 of those are in the ICU, and only 1 of those patients is on a ventilator. That's the good news. If you ask me why that's the case, I would say I think the reason is multifactorial, but certainly we are in a much better place now than we were, with a large portion of the community being vaccinated. Also many members being boosted, which means they've had additional vaccination. Also many individuals that have had natural infection and or a combination of all of those or both, leading to some form of immunity that's preventing some of the severe illness. It doesn't mean it eliminates it. It just means that it helps put us in a better spot. As far as the influenza cases are concerned, we have 21 patients currently admitted with influenza at BSA. That was this morning, and then I had an updated number that we're up to 23. We had a couple more come in our ER, and we are getting significantly inundated with admissions. We had 18 admission holds in this morning in our ER. That is a very high number. That is not normal for us here at BSA to have that many patients waiting for admission beds. And again, it's because of the high census. It's because of the demand on that inpatient service and need. And really, it's critical, as Dr. Weiss mentioned, that if you are having more mild symptomatology, that really going to the urgent care center, getting tested there or through your primary care physician's office, potentially other locations that don't require the hospital for the less severe illness is critical, so that people that do have more severe illness and conditions that require the hospital are not having prolonged waiting periods to be seen. Even when we do the proper triage of those patients, that can be a concern in terms of waiting times. I think it should be also noted that when you ask about our testing numbers, just to put this into perspective, although our total positivity rate for COVID now is only 9%, which is a low positivity rate. I told you that we were up to 22 admitted patients. For influenza, we are at a 32% positivity rate. That is a third of the tests we do are coming back positive. That's up from a week ago, we were at a 14% positivity rate. So in a 1 week's time, we have just exploded in terms of the positive flu cases. And that is 100% influenza A. So as you probably know, there's influenza A, influenza B. What we're seeing this year is influenza A. And again, the best thing you can do is to get vaccinated. If you're not vaccinated yet this season, I guess my first question would be, why have you been waiting so long? And the second comment would be, it's not too late to get vaccinated now. So do so. And again, it's not the vaccine necessarily that you get this year or this season, but it's your cumulative vaccines you get year after year for the flu that help to give you the best immunity. There's absolutely great data that proves that and shows people get less complications when you get regular vaccinations for influenza. So again, just to reiterate before I pass over to our remaining physicians on the panel, do the best you can, please, to protect yourself. Getting vaccinated, good hand hygiene. When you're sick, stay home. Follow the CDC guidelines for staying home, which is you should be at least 24 hours without a fever, off of anti-fever medicines before you are returning to work. The flu is highly transmissible. And again, the holiday season is a time when we're gathering, so you got to be extra diligent about those types of things. That's it for BSA and my update. Thank you.
Thank you, Dr. Lamentier. We now go to Dr. Todd Bell, Public Health Authority. Dr. Bell, how are you?
I'm doing good, David. Thank you. So I apologize for the voice demonstration and in action there. I'm getting over a virus as well. So I wanted to take just a minute to talk a little bit about how do we take care of ourselves when we've gotten a viral infection. The good news is that most viruses are going to cause mild to moderate disease that people can actually ride out at home or with the assistance of the primary care physician. And part of what we're seeing is that our strain on the healthcare system is when we have folks with mild or moderate disease that are seeking care, like at emergency rooms and places that are really designed for higher acuity, for more sick patients, patients with chest pain or strokes. We need to make sure that we have open access for those folks with severe illness, that they're able to get in and see their physician in those emergency settings in a rapid manner. So some of the same things that your grandmother told you about taking care of yourself when you have the flu, making sure that you stay hydrated, staying home, staying warm, not overexerting yourself, but also not laying around in bed all day, making sure that you get up, get moving around. Those are all important things for being able to care for yourself at home. Unfortunately, there are no medicines that are magic bullets on viral infections. There are situations where your primary care physician can prescribe medicines to make some things better, or at least go away a little bit faster, like the flu. Likewise, if somebody has COVID and is at high risk of complications, there's medications that can help decrease the risk of hospitalization after a COVID infection as well. But for most people, they're going to be able to ride out the RSV or the flu or the COVID infection without necessarily having any particular medications. I did want to point out a few things that are kind of red flags that would drive somebody, a patient, to go to an emergency room or urgent care and be able to seek rapid assessment. Because even though the majority of patients will have mild or moderate disease, There are folks who will have severe disease from the flu or severe disease from COVID, or especially in children, severe disease from RSV. So in kids, if we have a child who has difficulty breathing, if they're turning blue around their lips or their face, if especially in babies, if they're breathing and they seem to be sucking in between their ribs each time that they take a deep breath in. In older kids, if they have chest pain, if any child has difficulty with not peeing in at least 8 hours so that you're concerned that they're dehydrated, all of those things would be red flags that they need to seek medical attention. You may want to call your primary care physician first, but those would be situations that your primary care physician may then send you on over to an emergency setting. In children under the age of 3 months, really any fever that we see greater than 100.4, we want people to contact their primary care physician or seek medical attention, especially in children under 1 month of age, but really under 3 months of age. Those kids, that actually a fever warrants a trip to be evaluated by your primary care physician or an emergency room in real time. And obviously, just like adults can have chronic medical problems, children can too. So if a child has a chronic medical condition that seems to be getting worse because of the viral illness that they have, whether that be asthma, chronic lung disease, or any other chronic medical issue, those may be reasons to seek medical attention emergently. For adults, there's a similar list. We see that if an adult has difficulty breathing or is consistently short of breath, if they have chest pain or persistent chest pressure, dizziness with standing or confusion, inability to wake up in adult, obviously those would all be red flags that someone needs to seek emergency medical attention. If an adult hasn't been voiding or urinating either, haven't been drinking, dehydration can cause lots of significant issues for both adults and kids. If an adult is very weak or is unsteady, they're not able to stand up, catch themselves and walk without staggering. And then again, same as in children, if adults have worsening of their chronic medical problems, then that may be something that warrants medical attention as well. So we want to encourage people to be able to utilize the most appropriate care for their particular medical condition. That not only helps save them money and oftentimes time to be able to contact their primary care physician if that's appropriate, staying at home if that's appropriate, and going to the emergency room if that's appropriate. That also helps the healthcare system and make sure that we have access for those folks who have severe illness. With that, I turn it back over to you, David.
Thank you, Dr. Bell. Now go to Dr. Rodney Gonzalez, Director of the Amarillo VA. Dr. Gonzalez, how are you today?
I'm doing well. Thank you, Dave. So I will tell you, similar to the other two facilities, we have been seeing an increased respiratory illnesses. Right now we have 4 COVID patients, but as Dr. Weiss-Lamentier mentioned, that some of these patients have more than one virus. And we do have one that's got both influenza and COVID. And so those we always get a little more concerning about how this is affecting their overall system. When we look at our patients, we've got 2 in our ICU. But as like Dr. Lamentier said, for general, we're not seeing a severe illness on the COVID. And so we hope that continues to be the case. I will tell you, when you look at what we are seeing in general of our patients that come in that we do respiratory testing, influenza A predominantly is the biggest thing we are seeing, followed by COVID, and then the common cold, which is rhinovirus. And then we do see very small amount of RSV, as mentioned before, tends to be more of a pediatric population. Obviously at the VA, we do not see the pediatric population here, so we do not see quite as much RSV, but it is affecting adults because we are seeing some. And so as I mentioned, we have to look at the same things we did during other respiratory illnesses. And what we all remember did with COVID is, covering your mouth when you cough, sneeze, staying home if you are ill, vaccinations. Remember, we saw vaccinations, as mentioned, with influenza and COVID. And so if you've gotten your COVID vaccine and you're due for a booster, encourage you to get that booster. If you've not gotten your annual influenza, vaccine, encourage that. I've gotten both my influenza and COVID booster earlier this year. And so want to make sure that that continues. Here at the VA, we do offer both vaccines for our veterans. With COVID, we still offer COVID vaccine to spouses and caregivers for veterans. And so there are many other sources in the community to get those vaccines, but I want to make sure people know what we have here at the VA also. So thank you for your time, and I appreciate this.
Thank you, Dr. Gonzalez. Now I'm going to turn it over to members of our media right here via Zoom. If you have a question for an individual panel member or the panel as a whole, that's completely fine. Let's go ahead and start with Aaron Langston of KAMR Channel 4. Aaron, how are you today?
Pretty good. How are y'all?
Good, thank you.
Question number one, has anybody seen a patient with all three, like some of the national doctors have been warning us about possibly this year?
Aaron, we have not in Northwest, but boy, that would be a scary situation. You get all three.
We have not either. At BSA, we've seen co-infections with two organisms isolated and detected, but not three.
All righty.
Same
And
here at the VA.
sorry. And are we getting into a situation staffing wise, like we saw a few times with COVID?
Aaron, I'll start. So keep in mind is our staff are just as vulnerable to these viruses as anyone else. So the answer is yes. I mean, we certainly are seeing staff going down, getting sick with these viruses. And so again, just when we're seeing these peak patient numbers, we're also starting to see more staff calling in sick, and that just feeds into like what Dr. Lamentier was talking about is some of these long waiting times in the ED, some of these ED holds where people are waiting for beds. So yeah, it's the same vulnerability as when COVID was taking out a lot of our staff.
Yeah, and I think if you're asking if there's a nursing staffing concern, the answer is yes. There's still a national nursing shortage. So absolutely, we need more nursing staff. We're at any point when we have contract labor in our facility, which means individuals that are being hired outside of our employed nursing population, then we don't have enough nurses. Because certainly we'd rather not have contract nurses and rather have employed nurses if we could avoid them. That doesn't mean that the contract nurses aren't fantastic and do a great job. What I mean is they come at a much higher cost to our health system when we can't have that be a situation that's controlled more easily. So we need more nurses. There's a nursing shortage. The pandemic was part of the reason why there are still nurses that are traveling. Which they're doing some of those things to for their benefit of others and health systems that need them, that have greater numbers and other reasons. So we still are challenged by that, just to make sure we're all on the same page there.
All righty, thank you very much. And what is your concern, seeing the numbers in the hospitals that you are now with the testing and all that, and we're heading into the Christmas season where everybody's going to be getting together at some point with somebody that they normally wouldn't, and could be spreading any number of these illnesses that are hitting you guys hard right now?
Well, Aaron, go ahead, Brian.
No, and I was just saying, you expressed the concern very well. We're heading into the holiday season. Lots of people are going to get together, and yeah, that is a major concern.
All righty, that has me covered. Thank you very much.
Thank you, Aaron. We'll now go to Michael Cavello of the Amarillo Globe News. Michael, how are you today?
I'm doing pretty good. Can you hear me?
Yeah, we got you.
Okay. So my main thing is a lot of people, and I hate starting comments like that, but a lot of people are saying, well, we didn't have any flu deaths last year. So they're kind of like treating it like this is nothing new. It's just replacing what we call COVID deaths. What would you say to those folks? I'm sorry if that was awkwardly worded also.
Yeah. Mike, I'll take a stab at that. So it is correct that for the past 2 years, we've had very little influenza. And part of that is, and the primary reason for that is that the mitigation factors that are in place, the way that we've been able to try to decrease or minimize as best we can the spread of COVID has actually also decreased the spread of the flu. So if you think about certainly 2 years ago, lots of masking still going on, social distancing, people were very, very cognizant about if they're sick, they're going to stay home. If they have a cough, they're going to stay away from others. Last year, to some extent, the same thing, especially if you remember getting back into November of last year, we're right at the, with the Delta virus and having Delta hit. And so lots of people, again, are being very cognizant. And as they avoid those social interactions or are wearing masks, then that's decreasing the risk of flu spread. So flu just never got a critical mass over the past 2 years. Now, what that ends up meaning is that this year we have a bunch of folks who maybe haven't gotten their flu shot because, hey, I hadn't heard anything about the flu for the past 2 years, and so they didn't get their flu shot. Or even for those folks that may have otherwise have gotten the flu last year or the year before, now they haven't had exposure to the flu in the past few years. We have lots of easy targets for the flu to hit. So what we've seen then is the flu has come back with kind of a vengeance in order to be able to fill up that gap or that vacuum that has been there for the past 2 years, because this year we're not doing masks, right? You don't see large numbers of people in social gatherings that are masking. People have started being more comfortable with going to work with a cough or sick. And unfortunately, that contributes to the spread of lots of different viruses.
Also, do you think that a lot of the attacks on some of the precautions that we take it for flu or we take for COVID, do you think some of the attacks that have come on some of those processes are kind of a reason why people are more susceptible to the flu this year?
Well, certainly there's been a lot of politicization of epidemiology, science, and public health discussions over the course of the past 2 to 3 years, and got no interest in rehashing all that right now. What I would say is that there's we know that masking, especially if someone is ill or thinks they might be ill, if they're wearing a mask, that's going to decrease the risk of spreading infection to others. Unfortunately, some people then have started to equalize wearing a mask with certain political leanings or with certain worldviews. Mask doesn't care anything about those type things. The virus doesn't care anything about who you voted for. We know that masks decrease the risk of viral infections. And honestly, the last 2 years is a great demonstration of that. When people were wearing masks, we weren't getting as much flu. So hopefully we'll all be able to just kind of gather around what we have of the science and agree on the science and be able to leave some of those other controversial discussions to the side.
And my last question would be, are hospitals having to take extra measures to protect staff, protect patients when they come into the hospital because of the kind of the outbreak of the flu now, like the masking inside the hospitals or not?
Michael said at Northwest, we've not considered bringing the mask back yet, but certainly, again, over the trend over the last couple of days has been very concerning. But other than that, we do maintain just the standard hygiene practices, hand hygiene, obviously wearing masks. We still wear masks up in patient rooms, so that's still part of our plan. And then obviously any other personal protective equipment needed when we do have someone with flu or one of these respiratory viruses once we've confirmed they're positive.
That's all I have. Thank you.
Thank you, Michael. Let's now go to James. Excuse me, I forgot your last name. James of KGNC AM Radio. James, how are you?
I'm doing well. Thank you, ladies and gentlemen, for joining us today. Just a couple of questions. One, kind of a general one to start. I forget which one of you mentioned this earlier, but you mentioned that the influenza A this year is the more common one. Why is that? And is there any relationship between the commonality of the influenza A strand and the commonality of certain COVID variants around the region?
I'll take a step at that one too. So short version, influenza A versus influenza B, it's a little bit of a roll of the celestial dice. We don't have a great understanding of why one typically predominates. In a typical flu season, though, you only have one or the other, usually. Occasionally, there will be two spikes or peaks in the epi curve that happen 6 to 12 weeks apart. Influenza A is usually about 4 years out of 5. Influenza A will be the most common influenza type that we have that's circulating. There is no correlation that I'm aware of between influenza A versus influenza B and any particular COVID variant that is circulating. What I would say is that COVID, just like influenza, uses the opportunity of an infection to change itself just a little bit. The more people that get infected with either one, the more variants that develop, and the greater the likelihood is that we will have ongoing spread in the community. So when we're able to avoid somebody getting infection, then that cuts off an opportunity for the flu or for COVID to be able to mutate further.
Thank you. And my last question, do certain variants of COVID make it more or less likely to come down with RSV or with influenza, either one of those?
Yeah, to my knowledge, and as best I'm aware in the literature, there's no data to show that having COVID is necessarily going to increase your risk of getting RSV or getting flu. There are some theoretical connections that you could make between different types of infections. But again, specifically as far as solid data between COVID and flu and COVID and RSV, I'm not aware of any.
Thank you. That's all I have.
Thank you, James. Let's now go to Sydney Batzliff of KFDA Channel 10. Sydney, how are you?
Good. How are you? Thanks for having us.
Good.
So I guess first of all, just if you can kind of generally just say who is being most affected by this in your hospitals, and kind of what groups are you seeing most affected?
Well, I can start there. And again, more commonly, we're seeing patients that are elderly or older that are coming in with the need for admission for respiratory illness and disease. Those that have comorbidities, so other folks that have chronic lung disease or chronic kidney disease, other things that, again, suppress their immune system and inhibit their ability to fight off infection more rapidly with a natural immune response. So that's the typical. RSV is, as we mentioned earlier, typically a pediatric virus. And again, it looks like it's really acting as a cohabitant, if you will, for some of the folks that have influenza now in the adult population. But again, typically we're seeing folks that are older age, those that are immunosuppressed because of a medical condition, and then the young pediatric population. But that being said, I look at the infections every day that we have folks coming in with COVID-19 and some of these other infections, and we still continue to see some folks that are not elderly, that are younger adults that are coming in and need admission. And if you asked me to look at the characteristics of those, I would say it's pretty consistent that although some folks that are vaccinated for COVID-19 are coming in and getting admitted for COVID, it is not common that they are fully vaccinated, which means they've had the primary series and they've had all their boosters, including the most recent bivalent booster that's been available. Those would be a minority of cases that have required admission.
And then my next question is just how are you guys managing capacity? Anything specific that you guys are doing to deal with that?
I'll start and just say day to day. I mean, it's really a challenge in terms of what we're trying to do with throughput. And, our hospitalist physicians who manage the bulk of our medical admissions, of our 300 and I think I said 16 patients that we have in the hospital, 192 of those are on our hospitalist service. That is a tremendous number for that group of physicians that are managing those patients. Our intensivists, that are the medical specialists that work in critical care, along with the hospitalist physicians who work in critical care, are managing the sickest patients in our facility, and they're doing an outstanding job, all of them working very hard to do so. The nursing staff is working tirelessly, and really there are times when our ratios are not what we want them to be in terms of the number of patients they're taking care of because of, again, difficulties with trying to keep those beds staffed. It's not the physical beds. It's like we said before with the COVID peaks. It's the staff beds that become an issue in terms of our busiest times.
Yeah, well, I echo everything Dr. Lamentier said. Our hospitalist team also very, very busy right now. And the only other thing that I'd add is, one thing we're seeing is, we get pediatric patients who may have conditions other than an infection that need a higher level of care. Maybe going to Dallas or Fort Worth to the big children's hospitals there. And we've really struggled to try to find places to send these children to a higher level of care, just because so many children's hospitals are so occupied now with children suffering from RSV. So that's been a big challenge, is trying to be able to move kids to where they have the expertise needed to take care of some of these more challenging conditions.
And then my last question would be, have you guys had any diversions of ambulances at all?
We try very hard to not have patients diverted at all. So I'll start off in that fashion. I know Dr. Weiss is going to say the same thing. With that being said, yes, there are times when we've had to go on diversion simply because we're not able to confidently feel like we're going to be able to manage that patient potentially coming in from an outside rural community as fast as they may need to be managed. And we're trying to balance the concern about the risk to that patient. So there are times when we have to go on diversion. We've been working very well with our regional EMS leaders to try to minimize those times. And we, in fact, have statistics that we track closely month to month that show our diversion hours have been drastically down to very minimal numbers of diversion hours over the past several months. There are times when we have to go on diversion, though, because it's not a situation that we think is safe to tell a patient to wait that long to receive medical care because of the current volumes we're experiencing.
So yeah, absolutely. I would say the same thing in Northwest. I think usually our first decision point is, when a regional facility, one of these facilities that's out in some of the smaller communities, when they call us saying, hey, we really need you to transfer this patient to you, that's our first decision point. We say we just don't have the capacity to handle that patient. But we try not to block any ambulances driving in, but we may say no to some of these regional facilities looking to try to get a patient to a higher level of care, which is unfortunate because they need that patient sent someplace for this higher level.
Thank you.
Thank you, Sydney. We'll now go to Trayvon Gay of KVII Channel 7. Trayvon, how are you today?
I'm doing good. Can you guys hear me?
Yeah, we got you.
All right, cool. For the health department, I wanted to ask, what is the city doing to, educate or re-educate the community of make sure this curve of heightened infections going around?
So that's a great question. I think, opportunities like this are really important. We have also sent out communication to our healthcare providers. We have a flu report that is generated every week that's on our public health website, so that that we all here in our community have visibility on what the flu numbers look like, and we can see that they're certainly increasing. So we want to make sure that people are armed with the information that they need to make great decisions. We have COVID vaccine available at the public health department. So if you need your vaccine, that's certainly available today. We may have some flu vaccine left. I'll have to certainly check with our team, but flu vaccine is available at most pharmacies, your doctor's office. So there are a lot of opportunities for vaccination here in our community as well.
And then my next question for you guys is, are we at a spike that is making us close to a mask mandate? Why or why not?
No, sir, that decision has been made for us, but it is a tool. Masks are certainly a tool that we can use, especially when we're in public settings or in indoor settings. It's a great tool. Dr. Bell, did you have something that you wanted to add there?
No, I was just going to reiterate the same thing that, hey, mandates, no mandates again, and there won't be mandates in the state of Texas. That's just not going to happen from a political standpoint, if anything else. But, even if they didn't have a state law that said I need to wear a seatbelt, I'd still wear a seatbelt. You know why? Because it's a good idea. If I'm driving down the highway, I'm going to have my seatbelt on. Now, if I'm driving in my driveway, I may not wear one. If I'm going out into a place where I think that there's going to be a risk of exposure, if I sound like I do right now, where even though I'm pretty confident that I'm no longer infectious, if there's any risk, I'm going to put on a mask, just like if I was out on a highway, I'm going to put on a seatbelt. So I think that irrespective of whether there's a mandate, people can make the decision to do something and use something that's a tool that is able to help protect those around them and to protect themselves.
Okay. And so for the hospitals, with you guys talking about the possible cases or not possible cases, other cases being higher this year, how are the numbers compared to December last year and December of the pandemic years?
Trayvon, I can sure answer that one. So right now we are at the same level that we were at our peak in 2021 for our flu A cases. So we're certainly seeing a higher number of cases reported so far, which is why we want to, talk about vaccination and those prevention efforts. If you're sick, stay home. That's such a critical point. Anything that we can do to slow transmission and slow sharing our germs with one another this holiday season is really important.
Okay. And then for the hospitals, I believe Mr. Weiss, you said that you guys were 200% over original capacity. And then also at BSA, you guys were at a very close to capacity levels as well. How are you guys dealing with overflow?
So just to clarify, so I was talking about that we are seeing 200% of our normal capacity in the emergency rooms, our little satellite emergency rooms. So these are not, out of those, only a small fraction, thankfully, have had to be admitted to the hospital. So we're not worried about overflow in the hospital. It's just, boy, in those emergency rooms, it's a hopping place, and they're really trying to move patients through quickly. But right now, we're still doing okay on hospital capacity, though. Like what Dr. Lamentier said, we are seeing double-digit holds in our emergency room, meaning that there's 10 or more patients every morning waiting for beds. And this is relatively new. We were doing great for months where we really had no holds or just maybe a couple patients waiting for beds.
Yeah, I mean, we're working through it is the answer here, I would say, the short. And that is that we're not at max capacity, but we're certainly getting close when we're up in that 316 number, as I mentioned, at BSA. And just to reiterate or underscore what Casey said about the flu cases for the community, if we're at our peak now, the end of November, this is still the beginning of flu season. And I can tell you at BSA, we did not have anything close to a 32% positivity rate for our flu tests last year or the year before. So clearly, some of the things that were being done in the prior 2 years with masking and whatnot were diminishing our risk for flu spread. And now that we're in a different state in terms of what we're doing with masking and whatnot, and some of the evolution of those viruses that typically happen, this is a much different influenza year thus far. And hopefully it doesn't get worse. Maybe this peaks out and we're going to be done. But the likelihood of that when we're in the end of November is low.
Okay, that's all I had. Thank you so much.
Thank you, Trayvon. This concludes our Zoom news conference today. I want to thank all of our panel members who took the time out to provide this information to the community. Thank you for your attendance. This is David Henry. I'm the Communications Manager for City of Amarillo. And thank you for your time.
Thank you.